Thank you. Good afternoon, everybody, and thank you, Dr. Sood, for this opportunity. So I'll take it on from where Dr. Nayak left, understanding that you're all doing applanation tonometry and checking the CCT as well before you start treatment or progression in glaucoma, before you step up treatment. So elevated intraocular pressure is currently the only known modifiable risk factor for glaucoma, and the factors affecting intraocular pressure are the general factors: diurnal variation, IOP is higher in the morning versus the afternoon, IOP is also higher at night versus daytime. Posture higher in the supine position than the sitting position, and we all know that isometric exercise increases intraocular pressure. Systemic factors, you have the Valsalva maneuver, which increases intraocular pressure. Certain foods and drugs increase intraocular pressure, and in general anesthesia, ketamine and succinylcholine may increase intraocular pressure. So in the diurnal variation of intraocular pressure, higher diurnal and nocturnal fluctuations in IOP have been reported in glaucoma patients, and lowering intraocular pressure by 30% in patients will reduce progression compared to those in non-treated eyes. The risk of progression is lowered by 10% with each millimeter of mercury, and IOP peaks during nocturnal periods have been observed in healthy individuals as well. And Asrani et al. Reported that short-term daytime fluctuations of IOP do occur, so if you monitor your patient throughout the day, you would find risk factors for progression in a stable patient. So the landmark studies all point out to conclusions that patients treated early and aggressively had better visual outcomes. Lower intraocular pressure modifies other variables we cannot control, and IOP lowering offers the best neuroprotection as well. So if you look at that graph out there, the day-night IOP variation, this actually shows that nocturnal elevation of intraocular pressure in young adults as well. So this, if you look at it, both young adults and glaucoma patients have high intraocular pressure at night and in the supine position. And if you look at both of these graphs, you would see the triangles, the circles, and the squares, where the nocturnal intraocular pressure is definitely higher in both non-glaucomatous and glaucomatous patients as compared to others. So the possible nocturnal occurrences are: for elevated IOP, diminished outflow facility, hormonal changes, and direct pressure on the globe. And for nocturnal hypotension, it's the reduced ocular perfusion pressure. So from that, we can conclude that compromised optic nerve head circulation can lead to development and progression of glaucomatous damage in susceptible individuals. So the IOP fluctuation and glaucoma progression, what do we know about it? We know that IOP tends to fluctuate throughout the day and over longer periods. IOP fluctuation is significantly higher in glaucomatous groups than in normals. So that the chart that you see out there on your extreme left is the normals compared to angle closure, primary open angle, and all the p-values are significant in angle closure and primary open angle. So the relationship between intraocular pressure and the rate of visual field progression, this was a study done by Harsha L. Rao et al., and where they concluded that long-term IOP fluctuations was the most important parameter associated with the increase in the ROP of glaucomatous visual field loss. So IOP fluctuations throughout the diurnal period point that nocturnal supine IOP was higher than diurnal sitting IOP in patients with glaucoma and healthy subjects, and peak IOP occurred during the night as measured in the supine position, and the graph also shows you that. So the need for diurnal IOP measurements, you need to measure your patient throughout the day. IOP peaks during the nocturnal period. Clinicians usually assess IOP and therapeutic efficacy of IOP lowering agents during office hours. Single IOP measurements are never to be relied, as Dr. Nayak just told you, and 24-hour IOP monitoring studies have actually shown that higher peak pressures and wider fluctuations in IOP are observed outside the typical office hours. So you need to monitor patients for diurnal IOP measurement. 24-hour monitoring in patients has several advantages, like you can do aggressive IOP control. Analyzing a 24-hour IOP can reveal higher peaks and wider fluctuations that occur outside office hours. And doing this study, it has been found that this led to an immediate change in therapy in over 1/3 of patients when they were observed throughout the day and found that at certain time periods they did have IOP peaks, although they showed a stable IOP during office hours. So benefits of diurnal measurement of IOP in patients: individual management, that the response to IOP lowering medication varies from patient to patient and may reduce the rate of change in glaucoma, and improved treatment outcomes. Improved adherence of patients, that is important. You need to talk to your patient and explain that there are IOP variations and the timing of the medication that the patient has to follow and adhere to. And of course, identification of favorable and adverse behavioral and occupational patterns on IOP may be an additional benefit. So if you look at that chart out there, IOP over a 24-hour study can actually vary from 5 millimeters to 12 millimeters of mercury. So your office visit is not really the ideal place where you could actually judge the IOP of a patient. So IOP fluctuation and visual field progression, they go hand in hand, directly proportional. That's the reason you need to take care of intraocular pressure. And in summary, intraocular pressure is a sleeping giant, rising at night to play a possible role in glaucoma development and progression. Greater attention is needed to understand the efficacy of glaucoma therapy for providing a 24-hour IOP control. IOP tends to fluctuate throughout the day and over longer intervals. Large long-term IOP fluctuations are associated with progressive increase in visual field deterioration. Therapies increasing outflow appear to be better for stabilizing IOP than those reducing the aqueous production, and 24-hour IOP control is the mainstay of treatment. Thank you for your attention.